Good morning and welcome to this year's Health Economic Forecast. My name is Linda Lewandowski and I'm Dean of the Kirchhoff College of Nursing here at Grand Valley. Our college, along with the Seidman College of Business, serve as your GVSU hosts for this annual event. We're pleased to provide this platform to continue to showcase the Health Chalk data results about the health economic landscape in Western Michigan and to provide important data that will guide decision-making and address pressing issues to improve the healthcare of our communities. This is our 15th year of sponsoring this important event, and we're really pleased to have so many of you with us here in person, and also to all of those who are joining us online. Before we begin this program this morning, I have the privilege of introducing Dr. Philomena Mantella, the first woman and fifth president to lead Grand Valley State University. Among her many accomplishments, Dr. Mantella's commitment to growth and disruption is at the core of her work to redefine what higher education is for the public good. This event today is an example of the kind of beneficial academic community partnerships she's been so instrumental in promoting. Since she assumed the GVSU presidency 5 years ago, Dr. Mantella has created an unprecedented number of partnerships with the business and healthcare communities and is a recognized community leader helping to lead the economy of West Michigan forward. It's my pleasure to introduce President Mantella, who will give some opening remarks.
Well, let's thank our Dean, Linda Lewandowski, for hosting us today, and our Seidman colleagues as well. Thank you. I wish I could take credit for this tradition, but I actually can't. It predated me, and I thought, what a wonderful tradition to be early in a calendar year looking forward on one of our most critical issues. And colleagues, I see the word 2025 forecast, and I'm thinking to myself, wow, that's a high bar with a lot of left field activity happening in health. So good luck with your panel today. I spent a little bit of the week in New York with some business and industry leaders across health and really all industries and education, really with trying to forecast. And one of the things we said is some of our biggest disruptions have been those that are fully unanticipated. And I think in some ways what the mindset needs to be as we look at the question of health and health in the future and well-being, all the challenges we're having, is resiliency. How do we take some of what our colleagues will help us with, and how do we build that into a resiliency for not only our organizations, but our people who are trying to access healthcare before they need it, to stay well, and after they need it as they're faced with an illness. It's a pleasure for me to welcome you today to this event and to Grand Valley State University. I really want to thank the Seidman College and the Kirchhoff College for not only conceptualizing this, but really executing on every year, whether it was fully online, fully in person, or now in its hybrid format, which I'm really excited about because it does have a broader reach, and the connections to one another are so important across the state and across the country. Michigan is shifting quickly from manufacturing to a knowledge economy, and even manufacturing is changing in terms of the level of support and knowledge that's necessary to move the field forward, and healthcare is no different. There are so many important elements of healthcare that is about our mission, our community, our service, and these two colleges are deeply connected with service and community, as well as our students. For over 50 years, we can say our Kirchhoff College of Nursing has worked to face urgent challenges for nurses. We're proud of the partnerships we have in this area and the talent pipelines. We are doing everything we can to be sure skilled, compassionate nurses are in the workforce, particularly in Michigan. The ability to see what Michigan needs in the future is vital to preparing the talent and resources that are needed in a timely way today. You'll see today as well how the Seidman College of Business continues to build critical insight and expertise into not only the current data, But as I said, what's ahead, and trying to use this knowledge as a platform for forecasting, building resilience, building the future for our community. At GVSU, we believe that a university is more than a set of students, more than a set of classrooms, and that what inspires us every day is how this ecosystem can build a stronger community, a stronger economy, and a stronger learning experience. So thank you for being here. Thank you for your dedication to this work. I know how difficult this space is each and every day. I know how many challenges you face in education and in health. And I just want to, from the bottom of my heart, say thank you for staying in this field. We need leaders. We need you. And I hope you enjoy the day. Thank you.
Thank you, President Mantella, for that great welcome. Before we get started, there are a few procedural issues I want to share. First, this event is being recorded for later viewing as well as being live streamed. The link to this program will be shared on our website when completed and emailed to all the registered participants of this event. So you can share it with your colleagues and really have a broader view of the information. There'll be 2 Q&A sessions this morning. For our in-person participants, you have cards on your table. The moderator or someone will collect these cards. So if you have questions for the speakers, please use those cards. Online, if you want to put a question in the chat, we have someone monitoring that so we can use your questions as time allows. I know there's often a lot more questions that we can get to, but we really want to hear what you're thinking. I'd also like to extend a special thank you to our Health Economic Forecast Planning Committee for their ongoing support and leadership. For some of our planning committee, if you're here, do you want to stand up and just get recognized? Or we'll just recognize you anyway. We also want to recognize our community partner sponsors, Priority Health and Blue Cross Blue Shield of Michigan Blue Care Network. This year, each of them have prepared a brief video focused on issues relevant to the health check and the health issues we'll be addressing and their commitment to this work. Before we share the video from Priority Health, they've asked that we share a little bit more information with you, so I'm going to read their message to you. Priority Health is committed to improving access to equitable health care and promoting better health outcomes. The partnership to offer free virtual visits with Curai Health began in August 2024 for Michigan residents 18 and older who are without health coverage, about 400,000 people estimated. It seeks to address delayed care and poor health outcomes that can result from the lack of health coverage, promote access to care, and remove some of the barriers that prevent people who are uninsured from getting the care they deserve. The program was initially supposed to end December 31st, 2024. However, due to the success of the program, helping people access the care they need and more people hearing about it every day, they've just extended the program for another 6 months through June 30th, 2025, so that more people have the opportunity to get the care they deserve, especially as we enter into the cold and flu season. I think we're already in there, but there we are. Okay, let's hear their message.
More people are uninsured than many of us realize. Friends, neighbors, family members, even coworkers. With over 400,000 residents in Michigan alone, those living without insurance face uncertainty, overwhelming costs, and constant barriers. And more than half aren't seeking critical medical attention and preventive care because of it. At Priority Health, we're fighting to change this. We know enacting real, lasting change takes more than a mission statement and well-worded promises. It takes action. So we're taking action to challenge the industry's outdated status quo and to make healthcare coverage more accessible for everybody and everybody, physically, mentally, and financially. It's why we're partnering with Curai Health to cover the costs and provide access to free virtual visits for those that are uninsured in Michigan. It's just one part of our commitment to fostering a future where healthcare is simple, affordable, equitable, and exceptional for every person in the communities we're fortunate enough to call home.
Again, thank you to Priority Health for their continued sponsorship. Let's give them a round of applause. Thank you. Now we're going to hear from Blue Cross Blue Shield of Michigan Blue Care Network. regarding their ongoing support of the health check and some of the important ways it impacts their work and the work of all stakeholders in the health arena.
Hi, I'm Joe Hune, President for the West Michigan and Upper Peninsula regions at Blue Cross Blue Shield of Michigan. And as I step into this role, I'm excited to work more closely with all of you to improve the health of our communities. Blue Cross and Blue Care Network have proudly sponsored Health Check for the past 15 years. And we believe this study is a valuable community resource that helps business leaders, academic organizations, hospitals and providers, and state and local partners in the area make informed decisions to address major issues in healthcare. We're glad to support Grand Valley State University with this important work, and we appreciate the opportunity to participate in its continued success.
The work doesn't stop when the report is presented. It's a tool we, as business professionals and community members, need to leverage to improve health outcomes, create stronger communities, and address social determinants of health, with the goal of making healthy living an equal opportunity for everyone. As Senior Medical Director and Associate Chief Medical Officer of Clinical Health Equity, Quality, and Experience, I can assure you that this goal drives the mission of our business at Blue Cross. This year's Health Check tells an important and timely story about the health disparities that continue to persist in Michigan, especially when race and income are taken into consideration. GVSU's analysis found that these factors are linked to differences in access to care, mental health outcomes, and rates of chronic conditions, among other things. At Blue Cross, we're committed to addressing these types of systemic inequities that prevent people from achieving their best health, because where you live and who you are shouldn't determine your quality of life. In 2016, we formed the Health Disparities Action Team, and in 2020, we established the Office of Health and Healthcare Disparities. Most importantly, we believe that the best way to make progress is as a team. It's by building on this principle of collaboration that Blue Cross Value Partnerships has prevented $6.3 billion in avoidable healthcare expenses in the 20 years since it began. It's why our patient-centered medical home and grants focus on whole person health, working with diverse organizations around the state to advance social determinants of health beyond just medical care. And it's why we strive to empower communities themselves to get involved in the solution by helping fund projects and organizations to close gaps in maternal health equity, create healthier school environments, fund low-cost clinics, and address food insecurity. As a physician, I've experienced firsthand the difference this all can make. Health Check helps us see the progress we've made, as well as the hard work we still have to do. It gives us the data to know where to focus our continued efforts toward improving health equity this year and beyond.
We hope that this report and the conversations that take place today and in the months ahead will drive us to come together as we explore making healthcare better for everyone. We are more successful when we're all a part of identifying opportunities and paths forward. Blue Cross and Blue Care Network are committed to remaining active and supportive partners as we make strides toward greater health equity in our communities. Whether you're a student, business owner, healthcare provider, part of a community organization, or a leader in healthcare, your role and your contributions are essential to this goal.
Thank you so much. We have Dr. Henry with us right here, our star. Maybe thank you for coming. Thank you. Let's give a big thank you to Blue Cross Blue Shield for their sponsorship. It's now my pleasure to introduce Dr. Jerry Simmons. I always get that wrong. He's a professor of economics in our GVSU Seidman College of Business, and he's going to be our moderator for this first part of the program as we get to the crux of the matter here. Jerry.
Thank you, Linda, and good morning. Our Health Check presenters today are Drs. Daniel Montanera and Cody Kirby. both professors of economics in the Seidman College of Business. Dr. Montanaro earned his doctorate in economics from the University of Western Ontario. He was previously a faculty member in the Institute of Health Administration at Georgia State University. He specializes in health economics and microeconomic theory, studying defensive medicine and its impact on healthcare spending and access to care. He also investigates applications of auction theory in designing efficient health insurance exchange mechanisms. Dr. Montanaro has published his research in the Journal of Law, Economics and Organization, Information Systems Research, Manufacturing and Service Operations Management, and the European Journal of Health Economics. He has served on the editorial board of the journal Healthcare Management Science, and in his consulting work has collaborated with Mathematica Policy Research in developing guidance for states regarding the best ways to incorporate competitive bidding into their procurement processes in Medicaid managed care programs. Dr. Kirby received his PhD in applied economics from Western Michigan University. At Western Michigan, he received the Graduate Teaching Effectiveness Award and the Elias Herrick Award for outstanding work by a graduate student. He specializes in econometrics, data mining, and data science, studying the different applications of machine learning algorithms as they relate to time series forecast modeling and forecast accuracy. He's received 3 different research grants to study firm research and development behavior and the effects of early college programs on students' post-secondary academic performance. And today we'll start with Dr. Kirby.
Thank you, Jerry. Good morning. I get to kick off with what I think is a great story. And it's a story of optimism here. If we look at our demand in West Michigan for healthcare here, then it's on the rise. If we look at different disease prevalence metrics, they're going to differ across region, across racial lines, and across gender lines. When we look at population, we're going to find evidence of a migration occurring between East Michigan and West Michigan. And as more people come into West Michigan, that demand's going to rise. If we look at the age distribution of our population, it's getting older. And as that age gets up there, these citizens are going to need healthcare. So the question then becomes, is our supply in a position to meet that demand? And that, too, I think, is a tale of optimism. If we look at labor, for example, on the employment front, it's up on average. Differs by occupation, but on average, it's up. If we look at job openings, these too are up in West Michigan. And more importantly, when we look at inflation-adjusted earnings, on average, these too are up. And this is really important, because what this does is it attracts new talent and allows you to retain your current talent. When we look at the university level, what we find is a redistribution from low return degrees to high return degrees that may be relevant to healthcare. So I think the future is promising as well. Now, when Dan takes the stage here in a little bit, he too finds some pretty promising results. In West Michigan, he finds inpatient, outpatient, and emergency department utilization is on the decline, with a capacity that's unchanged. In the occupations where wages are declining, or compensation is declining, he shows that you're able to attract talent still. Now, when he compares West Michigan to East Michigan, he's going to find a decline in expenditure on most chronic cases and a narrowing utilization gap between East and West Michigan. And if we look at a lot of our obesity-related conditions, prevalence is on the decline. So let me start with demand here. And our first factor, which is disease prevalence. This data comes from the Michigan Department of Health and Human Services, their Behavioral Risk Factor Surveillance Survey, which is a self-reported survey occurring annually between 2011 and 2023. Now, the Behavioral Risk Factor Surveillance Survey has a suppression rule that is in effect. For some strata of the population, if there's less than 50 observations, those estimates are going to be hidden. Now, when I reference West Michigan, or what we call COMA, this is Kent, Ottawa, Muskegon, and Allegan counties. And I'm going to refer to two time horizons in my research. When I reference the long run, this is what has happened to disease prevalence since the end of the Great Recession, roughly around 2011. When I refer to the short run, this is what has happened to disease prevalence since the start of the pandemic in 2020. Let's start with our first disease, asthma. And I'm not going to present stroke, that's actually in the report. It follows a similar trajectory. When we're looking at cases of asthma in West Michigan, it's on the rise, both in the long run and in the short run, for virtually all strata of the population, except for our non-white residents. Now, when I think of asthma, I think it's probably related to tobacco use. But when we look at cases of reported smoking, it's on the decline for all segments of our population. But I ask, is smoking actually on the decline, or are these consumers just substituting towards a different alternative? And when we look at e-cigarette use, it's comparatively up, completely nullifying that decline in traditional smoking. So let's take a look at our first graph here. This is the percentage change in prevalence for cases of asthma in West Michigan. The blue bar represents the long-run growth rates. The red bar represents the long-run growth rates. Blue bar represents the short-run growth rates since the start of the pandemic. And I'm breaking it up by different segments of our population. Now, if we look here, then we can see that reported cases of asthma are on the incline for roughly all segments of our population except for our non-white residents. And this holds both in the short run and in the long run. I think of asthma, I think of smoking. When we look at the prevalence of smoking, however, for virtually all segments of the population, it's on a decline. Again, I ask, is smoking on the decline, or are these consumers just substituting towards a different alternative? And that's where we look at e-cigarette use. When we take a look at e-cigarette use, it's through the roof, both in the long run and in the short run, almost completely nullifying the decline in smoking. So we're finding evidence of substitution. Our consumers are just substituting from traditional tobacco use to e-cigarettes. Now, when we look at our non-white population here, these estimates are suppressed. We don't have enough information on them. I'd love to be able to say something about youth e-cigarette use. Unfortunately, the survey only covers adults. So I can't say anything about the youth trends, but we can turn to recent research that has been released in the youth. If we look at the Michigan Department of Health and Human Services, their 2023 Youth Tobacco Survey, 16.5% of high school students report currently smoking, where 13.7% report using e-cigarettes. Now, what has happened over the last year? For that, we can turn to the CDC. The CDC finds that over the last year, roughly 20% of youth smokers have quit. And if we look at e-cigarette use in particular, that decline is about 24.5%. Now, when asked why we're observing this decline, the CDC actually cites a significant decline in youth usage. So I think that's promising. The second thing I want to talk about here is mental health. In West Michigan, we appear to be under a little bit of a mental health problem. If we're looking at cases of reported depression, they're up for pretty much all segments of our population. It just depends on how we define depression. If we look at clinically diagnosed depression, in the long run and in the short run, it's up among our white residents and among females. We're getting some mixed signals from our non-white residents and from men. And this isn't surprising because these segments of the population are less likely to get help and therefore less likely to be diagnosed. So we need some new way to measure depression among these communities. And for that, we turn to the number of poor mental health days. We consider somebody to be of poor mental health if in the last month they have had 14 or more poor mental health days. If we define depression this way, then we find that depression is up among men and among our non-white citizens. Now, there's probably a whole host of factors at play when it comes to depression, but the first thing I think is maybe it's related to alcohol. And when we look at alcohol, in the short run, among our men and among our non-white residents, they're up. And if we look at cases of binge drinking among females, it's up by about 13% in the long run. So let's take a look at depression. This is clinically diagnosed depression. And for all segments of our population, except for our non-white communities, our men, which is to be expected, we find increases in depression over the long run and in the short run. Again, not surprising here, because our non-white residents and our men are less likely to seek help, therefore they're less likely to be clinically diagnosed. So we redefine depression, looking at the number of poor mental health days. And we consider someone to be of poor mental health if they have 14 or more poor mental health episodes over the last month. That's pretty much undiagnosed depression. When we define depression this way, we can see that our non-white residents and men also appear to be going through a problem. When we look at alcohol consumption, at least in the short run, it's significantly up among our non-white residents and among our men. I don't present binge drinking here, but if you look in the paper, at least in the long run for our females, it too is up by about 13%. I want to also be able to talk to you about the accessibility of care and the cost of care. When we look at the number of people reporting having had their annual checkups within the last year, and we look at insurance coverage, these are on the rise, both in the long run and in the short run for all segments of our population. When we turn to the cost of care, we get a slightly different story here. In the long run, less people are delaying care for reasons related to cost, and they're getting help. And this isn't surprising, because since the end of the Great Recession, the average inflation rate in West Michigan is 2%. That's perfectly consistent with the Federal Reserve's target for what a healthy-looking economy looks like. In the long run, West Michigan has a very healthy economy. When we turn to the short run, since the start of the pandemic, we get a different story. In the short run, more people are delaying care for reasons related to cost. And when we look at the average inflation rate, what we see is it's 4%, double the Federal Reserve's target. Our households are strapped for cash, and therefore they're more likely to delay care for reasons related to cost. So here's the growth in the respondents receiving annual check-ins over the last year. For all segments of the population, both in the long run and in the short run, it is up. More people are getting their annual checkups. When we turn to the number of respondents reporting not having access to health insurance, this is on the decline. The synonym here would be more people have health insurance, both in the long run and in the short run. It's a good thing. More of our citizens are covered. And now, when we turn to those reporting not having care for reasons related to cost, now we get that economic effect. In the long run, less people are delaying care for reasons related to cost. In the long run, West Michigan's economy is healthy. In the short run, since the start of the pandemic, more respondents are delaying care for reasons related to cost. In the short run, our households have been strapped for cash. Something interesting is happening among our non-white residents here. In the long run, they're reporting having had more annual checkups and more access to insurance, but they're also reporting delaying care for reasons related to cost. So how is this possible? And I think the answer is in the survey. The cost of care is not necessarily the cost of a checkup. Checkups are cheap, relatively speaking, and they're often covered by insurance. If you're covered by insurance, more people are going to go get their checkup. But what about elective procedures that are outside the scope of insurance? It's possible that these citizens would like these elective procedures, can't afford them, at least in the short run. And therefore, they have to delay care for reasons related to cost. When we look at population, I take data from the US Census. Again, West Michigan is Kent, Ottawa, Muskegon, and Allegan counties. East Michigan, or Detroit, is Oakland, Macomb, and Wayne. I'm taking annual data from 1991 to 2023. When I study population migration here, we're going to see that in Detroit, the population growth rate over the last few years has been negative. When we turn to West Michigan, however, it's comparatively positive, suggesting there might be a migration underway from East Michigan to West Michigan, driving more people here. When we look at the age distribution of our population, the 65+ community is growing. As people get older, they're going to require more care. So this time series shows the population growth rates in the US, Michigan, West Michigan, and East Michigan. And I'm going to turn your attention to the navy blue and light blue lines. The navy blue line is what is happening in West Michigan. The light blue line is what is happening in East Michigan. If we look over the last few years here, what we can see is that population growth rates in Detroit have been negative. They're comparatively positive in West Michigan. More people are migrating from East to West Michigan. When we look at the age distribution of our population, I want to focus on this light green line here. Our population is aging. It's getting older. And as it gets older, it will need more help. I also want to be able to say something about labor and our supply side here. So I take data from the US Bureau of Labor Statistics. Now, when I reference healthcare employment, what I'm doing is I'm just summing across all occupations within some region. When I compute the average inflation-adjusted earnings, however, the first thing I'm going to do is I'm going to take the average earnings in each occupation, adjust them for the rate of inflation. Then I'm going to take a weighted average, where the weights are determined by occupation within each region. So the left pane here looks at the percentage change in healthcare employment since 2005, the right pane since 2022. If we look at West Michigan, over the long run, what we can say is employment has significantly grown. It's outpaced both the state level and the national level. When we look at what's happened over the last year, however, we're getting a different story. However, I'll still point out that employment growth rate is positive. We are still bringing people on board. When I look at the average inflation-adjusted earnings, it tells a very promising story for West Michigan. Both in the long run and in the short run, average earnings for our healthcare workers exceeds both the state level and the national level. This is going to attract new talent. It's going to retain the existing talent. I want to be able to say something about education and what we're doing at the university level. So I'm going to piece together a whole bunch of different sources. When I refer to employment, these are individuals currently attending. When I refer to a matriculant, these are new people currently attending. Those who have applied, been admitted, and are in their first semester. And I'm looking at the most recent year of data. What does our future look like? Well, it's no surprise, but university enrollment has been on the decline for a bit now. But I ask, is that relevant to you? Do you care about the art majors, or do you care about someone who's trying to get a job in health? When I ask that question, I get very different results and very optimistic results. If we look at enrollment in PA programs, it's up by 6%. If we look at nursing enrollment, it's up by 6.5%. If we look at enrollment in programs that have been known to lead to med school admissions, it's up by 2%. And if we look at med school in general, it too is up. So I think the future looks promising. I think my question to you is, okay, if the future looks good, what are you going to do to attract them? What are you going to do to retain them? And that's all I got for you. I'm going to hand it over to Dan. Thank you guys for letting me speak.
Would you believe that's Cody's first year on the project? You'd never know it. One more time for Professor Kirby. Thank you for being here, everyone, especially the students. I'm seeing a lot of students. Even some of my own students are here. Brought my cheering section with me. As Cody said, we get to bring a lot of good news this year. We can't say that for every health economic forecast, but I've got some good news and some weird news. And if we make it that far, I'll tell you what I mean. This is the benchmarking communities section. So here what we did is use American Hospital Association hospital statistics data to essentially build spending, utilization, and capacity variables for a set of 4 communities. The idea being that if we compare trends across 4 communities, then it can give us an idea, help us narrow down whether what's going on is due to factors at the national level, at the state level, and so on. Let's take a look at our communities. It's a little tough to see the colors. I guess it's not that bad. Grand Rapids is in navy, and that's the trend you see at the bottom there. What we're looking at, this is hospital admissions, but let's focus on the communities first. We want to compare Grand Rapids against the national average, because that's going to tell us if we see movements in kind between those 2 trends, that it's likely due to national factors. We've also got Detroit in green, so that way if we see common movements in green and navy, that likely due to state reasons or state factors. And then we have what we call the benchmark communities. So this is where we took a set of 4 cities that are similar to Grand Rapids in terms of size, demographics, industry, age, etc., and kind of made a convex combination of the 4. So if you see common movements between red and navy, that's signaling that there's something about the composition of Grand Rapids and its industries and its people that is likely behind changes. And then every so often, Grand Rapids goes off on its own. And in that case, it's a little difficult to pin down what it is that's driving the changes. As I said, we're looking at hospital admissions here per capita. And throughout the history of this health check report, Grand Rapids has always been at the bottom in terms of hospital admissions per capita, to the point where we started to think they'd found the floor. And you see that if you look at the COVID years, 2019, 2020, when hospitals across the country had every incentive to keep everybody out of the hospital that they possibly could. You see admissions dip in all the communities, except Grand Rapids is barely a dip, which kind of signals that already have kept everybody out of the hospital that possibly could be, and and couldn't move any lower for the reasons of COVID. Then 2020 happens, and we see a dip, not just a little dip, but that's a 10% dip in admissions per capita, to the point now we're at a record low in terms of the history of the report. We're just above 80 admissions per 1,000 population. First of all, in terms of, is that a good thing or a bad thing? In one perspective, it's a good thing. Hospital care is quite expensive. It's an expensive place to deliver care. And in respect to the decades-long trend to try and bring care out of the hospital, out of an inpatient setting, and treat it on an outpatient basis. In that sense, good news. What's driving it? It's not population growth. Population growth was pretty low over these 2 years. It's picked up since, but 21 to 2022 is less than 1%. It's not a capacity issue. Capacity actually grew by 1.5%. Grand Rapids has been healthy, like in terms of risk factors. It's a fairly healthy community. Did we become healthier? I don't know. I want to show you next. Outpatient, oh yeah, that's the other thing. And it's not due to substitution from inpatient to an outpatient settings, because as you can see, we've still got Grand Rapids and Navy here. Outpatient care also declined. Outpatient visits per capita also declines. So, interesting. I don't know why. It's a good question. In terms of outpatient visits, for the last couple of years, it looked like Grand Rapids was off into the stratosphere in terms of outpatient visits per capita. Even as other communities were dipping, Grand Rapids was rising in outpatient care utilization. 2022, we see kind of a return to trend and a return to about the same relative positioning that we've seen, going back a decade or so. So good news in the sense that utilization spending down on both an inpatient and an outpatient basis. This got a lot of time last year, so back up. So in terms of emergency department utilization, Grand Rapids has always been about at the national average, so nothing spectacular in terms of emergency department utilization. Detroit has always been in a league of its own, going back to the beginning of this report, except for 2021, where you can see Grand Rapids suddenly jumps a tier, and it looks a lot more similar to Detroit in terms of the rate at which we're utilizing the emergency department. Concerning, because as we know, the emergency department for a lot of types of care is not the most efficient way to deliver the care in terms of how expensive it is and how effective it is. At the time, we looked into reasons. Some of them could have been temporary in nature. There was the Delta variant onset in Grand Rapids was quite severe. Early onset of some winter illnesses, so would have been attributed to 2021 instead of 2022. But also identified another reason, mental health related visits to the emergency department. There's several news stories and testimony from practitioners on the ground, mental health related visits to the emergency department. So in terms of good news, it looks like for 2022, we're basically back where we were, and it's at least, it's only one data point, but it signals that the reasons for that spike were suggestive that they're temporary in nature and not part of a longer run problem. So that's more good news. On to hospital-based personnel. So Dr. Kirby talked about this. You can see in the COVID years, actually I'm going to flash between these two. In terms of the number of personnel, you see the declining numbers during the COVID years, and in Detroit is actually even a year earlier that it begins. This is despite compensation rising. So compensation, even though compensation is rising, hospital personnel is falling. So we interpreted that for the last couple of years as evidence of burnout among hospital personnel, and that was reflected in the literature. It was finding burnout among nursing staff especially. More good news is it seems that Grand Rapids, again, is turning the corner a little bit quicker than our other communities. We see a rise in hospital-based personnel going from 2021 to 2022. The greatest increase, slight increase in the national average, but it's not because of having to raise compensation. If you look, this graph is average payroll and benefits. You can see that Grand Rapids is the only community where it actually declined, right? So that speaks to the ability to attract hospital-based personnel, attract talent at competitive rates. That there's something about Grand Rapids that they're willing to have their career here without us having to outbid every other community. Good news. Now, to qualify, this is not necessarily saying that the same group of hospital-based personnel are now getting paid less. There's also, it doesn't take into account compositional changes like how many, the experience level of the positions, some suggestive evidence of backfilling. So when a higher trained hospital employee leaves, backfilling with younger, less highly trained personnel, that would explain what's going on. But anyone in personnel able to attract talent without breaking the bank, necessarily good news for Grand Rapids as a whole. It's not all sunshine and rainbows. There's a couple indicators that on the surface look a little concerning. So we're looking at average hospital length of stay here. Grand Rapids enters the year the lowest, but has had the fastest rate of growth in average length of stay. And also in total hospital expenses per admission, Grand Rapids is there at the top with it's the highest, and it has the greatest rate of growth year over year. On the surface, a little bit concerning, worth monitoring, but if you keep in mind that we're basically not far off the long run trend for either one, and the relative positioning is about the same going back 20 years. So worth keeping an eye on, but not necessarily becoming concerned about right now. Major medical conditions. So previous slides were all based on American Hospital Association data. We are now looking at data provided by our community partners, Blue Cross Blue Shield of Michigan, Blue Care Network, and Priority Health. They went alphabetical on that one. Hope that's okay. Alphabetical. And what we used our data to do is construct measures of utilization and spending across 6 chronic conditions as well as we construct a measure for spending and utilization for what we consider healthy members of the insurance plans. And it's still good news, not so much good news for Grand Rapids this time as good news for Detroit, but I am going to qualify that towards the end of my talk here. This is the year-over-year percent change in average expenditures. So let's focus on greater Grand Rapids region or West Michigan, that's in Navy, and we see increases in expenditure per member of our 6 different chronic diseases. Let me see if I can get them all. Asthma, coronary artery disease, depression, diabetes, hyperlipidemia, and low back pain. It's not as impressive as you think. It's written on the board. But I said them all properly. And then healthy members is there at the top. So you've got growth in spending in West Michigan, but not out of line with what we've seen in previous years. What stands out is the Detroit data, and you can see almost across the board we've got declines in spending per member. In some cases, big declines in spending per member, like low back pain. On the surface, terrific news for Detroit, but something we have to keep in mind is that 2022-2023 coincides with the Spectrum-Beaumont merger, and there's a lot of new members showing up in the data over the past 2 years. From last year to this year, it's about 27% growth in the Detroit region, but low growth in the Grand Rapids region. So essentially the distribution, the composition of the data in the Detroit region is changing much more so than the Coma region. So that's a pretty big qualifier with everything I'm going to show you moving forward. The other news is there's always been a gap. In our utilization members, there's always been a gap basically across all conditions in terms of a regional difference in utilization for this. We're looking at inpatient visits here. Detroit has always been above. And that doesn't change this report, but this is actually the narrowest this gap has ever been since I've been on the report, since 2020. So I squished last year's graph into about the same dimensions so that you can see how that gap has been narrowing, particularly coronary artery disease, depression, and low back pain. So more good news in terms of, for Detroit anyway, in terms of narrowing the gap with the rest of the state in utilization per member. Similar story for emergency department visits. Again, that's the big, you can see the gap narrowing there, essentially across all the conditions. And finally, for prescription fills. Gap's getting smaller. So this matters in terms of comparative advantage for firms setting up businesses. One of the things they consider is how expensive the health insurance is going to be, and that's tied to healthcare utilization. So again, good news for Detroit region. Last thing I'm going to talk about, I'm ahead of time for once. So I'm going to drag this out. Disparities. Disparities is where we took the same data and we wanted to see if the experience was similar for different income quintiles and whether changes were, or whether prevalences were different across racial groups. So I'll just dive into the numbers here. What we're looking at here is income disparities, and it's only emerged in the last couple health checks how severe the income disparities in prevalence of certain diseases are in Grand Rapids. We improved our methodology last year. This is our second year of doing it this way, and it came to light that, so what we're looking at here, we've got the 2 regions, east side of the state, west side of the state. The regional averages are presented in orange, so this is showing prevalence of coronary artery disease higher in the east side of the state than the west side. But then we take the data and we stratify. In this case, we're stratifying by income. So the navy bars represent the residents of the zip codes with the highest mean household income, and also represent 20%. So think of that as the high income quintile of the distributions for each region. And then we did the same for the low income zip codes. So separate out the residents of zip codes with the lowest weighted average mean household income. So for any of these graphs, anytime you see a difference between the navy bar and the green bar, we're taking that as evidence of a disparity in terms of prevalence of one of these chronic conditions. You can see, so this is by income, you can see by Detroit, navy and green, roughly the same height, not much of an income disparity there. But we do have an income disparity in Grand Rapids, greater prevalence of coronary artery disease among the residents of these low income zip codes. Now you're looking at this one. This is prevalence of diabetes, and I think you're thinking two things. The first is that there's clearly an income disparity in terms of prevalence of diabetes, and it's true all over the state. Prevalence of diabetes among the low-income zip codes is more than double the prevalence in the high-income zip codes. That's true for West Michigan, East Michigan. The second thing you're probably thinking is that, well, there's a disparity, but at least it's the same, right? Same on both sides of the state. Nothing remarkable about West Michigan or Coma region. And that would be true except for the fact that the income distribution is quite a bit narrower in the Coma region than in the Detroit region. So even though the incomes aren't that different or as different across zip codes in the west side of the state, the disease prevalence for diabetes is actually wider. So if you think of it this way, let's say you started at the high income zip codes and then you started traveling down to lower income zip codes, 1% at a time. In West Michigan, for every percent lower income you reached, the diabetes prevalence increases by 2.5%. Right? So the diabetes prevalence increases faster than your decreasing income. On the west side of the state, every percent income lower you go, it's only 1.5%. So what that's telling us is there's a much stronger relationship between the income of zip codes and diabetes prevalence in West Michigan than in East Michigan. And that's concerning. That's exposure to a chronic condition to a vulnerable population. That's concerning. We're moving on to racial disparities here, and here's the weird part that I promised you at the beginning. So we said there's good news for Detroit region. We also said that's qualified because the data has changed in terms of composition quite a bit from last year. We don't see Coma change much. I'm going to compare this against last year's numbers for a second. But the point I want to get across is that this good news is not really evenly distributed across all the zip codes of Detroit. So bear with me here. There's last year compared to this year, right? So you can see not a heck of a lot of change in the Coma region because the member months didn't grow as much. But look at the good news in terms of declining coronary artery disease prevalence. The good news is mostly concentrated in the quintile that has, so again, this is racial disparities. So now Navy represents zip codes with the highest weighted average share of white respondents in the census. So the declining prevalence is mostly concentrated among the zip codes with a high share of white residents. Not as much movement for the high share black zip codes. So what you see in green, that's the zip codes that have the highest weighted average share of black respondents in the census. We see that for coronary artery disease. This is hyperlipidemia. Again, from the look of it, it looks like the racial disparity is worse in terms of Coma than in the Detroit region. You can see that's the result of the big change in essentially the reduced disease prevalence for the high share white zip codes, not as much change for the high share black zip codes. So to the extent that this, not data issues notwithstanding, to the extent that this represents good news, we can't really say that the good news is evenly distributed. It seems to be highly concentrated in the zip codes with a large share of their population identifying as white. In that case, 2 minutes early, that's a record. We'll turn it over to Q&A, I suppose. Thank you very much.
Thank you to our speakers. We've got a couple of questions. So Dan, don't get too comfortable. You mentioned the Spectrum-Beaumont merger. Could you talk more as to how that might affect the results this year?
Okay, so ideally what we'd like this report to be is taking the same group of insured policyholders and following them over time so that when we see changes, we can interpret that as differences in this population's exposure to certain diseases or different changes in their utilization or spending. When you have such a large increase in the population in the sample coming from a different distribution set, these did not used to be priority health members. These are brand new priority health members that are essentially a different distribution. So that changes changes the averages and the standard distribution, the standard deviation of the distribution. So that makes it difficult to pin down any changes we see. Is that because our population is having a different experience, or is this because we are now looking at such a different group of patients now that it's grown so much? That's what I mean by it's difficult to pin down what's going on because of that merger.
Okay, thank you. Cody, a question for you concerning e-cigarettes. You showed that was on the increase, the usage. Any policy implications?
Hello. Great question. I think I could give you a very boring economic professor answer. When it comes to smoking, it imposes what we call a negative externality on bystanders. And this is an uncompensated effect that has to be paid by these innocent bystanders. So the question is, how can we discourage e-cigarette use? And I think the most popular way to account for this externality is through a tax. Now, you tax the good, the price goes up. Price goes up, more adults are going to consume less. But I think this is also disproportionately going to impact the youth, whom don't have the disposable income to pay the higher price. So I'd anticipate that would result in a large reduction among our youth. But I would also like to say, maybe that's also not enough. When it comes to youth e-cigarette use, I think the CDC report said that of e-cigarette users among the youth, 90% choose flavored products. And my question is, who is the cotton candy e-cigarette marketed towards? Because as an adult, I don't remember the last time I wanted cotton candy. I think that answers the question. Thank you.
Thank you, Cody. And Dan, you talked about the low hospital utilization capacity and the benefits there. There's going to be drawbacks, right? So what are those?
So in the one sense, utilization and capacity is going to be linked to spending, right? The more you're using it and the bigger the facilities, the more the capacity, it's going to translate to high spending, and that eventually finds its way to employers in terms of what employers are spending to insure their workers. So in that sense, having utilization low, having capacity low is good for how expensive it is for employers to insure their workers, and gives them, could be a comparative advantage for the region to have encourage firms to set up their headquarters and their facilities in West Michigan. So in that sense, that's what I meant by the benefits of having low utilization and capacity. But at the same time, we do know that Grand Rapids is quite healthy in terms of the underlying health characteristics and risk factors. So it could be that we are able to get away with this low capacity and low utilization because Grand Rapids is so healthy. Are we guaranteed to always be relatively healthy, right? We know we have an aging population, and we know that underlying health characteristics can change. So I guess that's a potential drawback should our underlying health profile, risk profile change. That could increase demand for these services and require more capacity than we have. So does that answer the question for you? So, okay.
Yeah. Okay, well, that's it for the questions that I had. So, Linda, back to you.
So let's just give them a round of applause for all of their presentation. I also want to call your attention to the fact that the full report is available online. We're hitting kind of the high points today, but there's a lot more in there. And so I refer you to, for your light bedtime reading, the Health Economic Report. We're now going to move to a panel discussion. So I'm going to excuse panel 1. And I'm going to ask our panelists for panel 2 to come forward. It's really a great pleasure to introduce our really high-powered panel representing a number of important community partners. We're going to have very brief introductions. They've agreed that we can kind of not go in their very long CVs, but let me tell you, there's a huge amount of expertise and accomplishments sitting at this table. We're going to begin this morning with Dr. Brandon Francis, who's the Chief Medical Officer at Trinity Health St. Mary's. You know, just sort of, yes. Dr. Francis is a psychiatrist with expertise in behavioral neurology. Our second speaker is going to be Dr. Clifford Cho, who's the new Chief Medical Officer at University of Michigan Health West. He's a renowned pancreas and hepatobiliary surgeon with over 20 years of expertise and experience. Our third speaker is Andrea Leslie, who's the Senior Vice President of Hospital Operations for Corewell Health, and who I just found out is also an alum of the Kirchhoff College of Nursing. So go Laker Nursing. We're very excited to have an alum here. And our final speaker is Elizabeth Hertel. Dr. Elizabeth Hertel is Director of the Michigan Department of Health and Human Services, and so we're very excited to have her come over to our side of the state today. Each panelist is going to have 10 minutes to respond to a set of predetermined questions. We gave them some questions kind of as prompts. They really don't have to answer each question, but we really wanted to focus on promoting a better understanding of the report and also some of their ideas for what's the next step. How do we really utilize these important findings? So we're going to start with Dr. Francis. Each person will have about 10 minutes.
Good morning. Thanks for having me. Just delighted to be here. Let's get started. We're going to talk a little bit about innovative solutions to the community needs that we have here. I'm going to start with looking at who Trinity Health is and our mission. We together serve in the spirit of the gospel as a compassionate and transforming healing presence within our communities. Notice it's not just about healthcare. It's about being a transforming healing presence in the communities. Being a presence means working with our partners, because none of us can do this alone. Trinity Health is a large organization. We're across the country. And here in Michigan, we have a bunch of hospitals and partnerships and collaborations across the state. And we use that to help people within this community here. We're going to start with behavioral health. There are a variety of opportunities in the field of behavioral health across the continuum, everything from an outpatient visit to social work to inpatient needs. But one thing is very clear from our colleagues here at the Health Economic Forecast: utilization in the ER is not always the best place for patients with behavioral health needs. And so we're going to look at a strategy to address that. First, we're trying to increase the support in the primary care offices. We're embedding behavioral health resources there. Why does that matter? Because of the long-standing relationships patients have with their primary care physicians. That's a great place to embed an additional resource for them. And in reality is, many primary care offices do a lot of behavioral health care on their own. So giving them the support and resources they need can actually help the population. We also have a psychiatric medical unit in our hospital, which has been taking on a lot of primary psychiatric care. The psych med unit is designed and staffed to handle patients with psychiatric needs that also have complicated medical needs. That is a special subpopulation of the behavioral health group. And we want to return it to that population. And we're going to have a few ways of trying to do that. We're in the process of building a 96-bed psychiatric hospital in partnership in the Southridge area. It's a big deal to increase the number of psych beds. If you can only imagine the number of patients that are sitting in ERs right now that need a place to go to get the care they need. So this is a big deal, and we're working on it. Should be open next year. We've also recognized that inpatient care is not always the best thing for patients. Sometimes they need more, brief interventions and support. Looking at what happens to patients that are in crisis, they will often end up in and involved with law enforcement, which may or may not be the best approach for them and their needs at that time. So how do we support them? Well, if we can create a crisis stabilization center that has resources to connect people to what they need and get them the support in the moment without going to the emergency room, without having to go to law enforcement, that can be a big change for the population, because we end up seeing that there are disparities in who has access to mental health resources and who gets them instead of going to prison. So let's take a look at this. We were able to build and open the first of its kind behavioral health crisis center on our campus. We have a no wrong door policy, which means regardless of your ability to pay, you have access to the resources and can use the facility. We've been partnering with our local law enforcement agencies to bring patients here first when they have mental health needs, rather than ER or prison. We initially thought when we built this that it would be used as a short, we're thinking 14, 24-hour stay to get the resources, and then they would transition back to the outpatient world. We're finding that patients are using this more as a short hospital stay. They're coming in for 24 to 36 hours. That's the need in our communities right now. So that's what we're serving them as. And we put this together between having an inpatient 96-bed hospital, a crisis stabilization center. We should start to see some improvement in the utilization of our emergency rooms, which are phenomenal facilities, but they're not necessarily the best place for behavioral health care to take place. They're loud, they're busy, and they're expensive. So let's use them for what they're really, really good at. This is what it looks like. For those that remember what some behavioral health facilities used to look like 15, 20 years ago, they were dark, they were cramped, they were thought of as an afterthought. These are people. Their disease simply isn't asthma or coronary artery disease, so they don't get the great centers. It's not breast cancer. They don't get the pretty ribbons. Well, we built this facility to look and feel like other clinics should look and feel. This is what a consult room looks like. I'm showing these pictures because it matters that we treat them like everyone else. They should get the same resources as other types of illnesses. That's part of ending the stigma of mental health care. This is a private room. This is what a staff room looks like. Looks like other nice clinics. We're really proud of that opportunity to work with our partners, Network 180, in developing that facility. We've served so far 1,500 patients. Very proud of our group, thank you. We're going to transition to the stroke program. I'm a neurointensivist and I've got a special love for stroke patients. And this is across the gamut from ischemic and hemorrhagic stroke. We've been really working hard as an organization. There are metrics for treating stroke patients. Things like, you've heard the phrase time is brain. Yeah, it's a big deal. For every second that you have a lack of blood supply, you start losing brain cells, millions of brain cells. So it's a big deal. We have the best door to needle time. So that means when you come in to actually getting medication to help hopefully break up the clot, the shorter time is better. We have the best one in Michigan. We're very proud of that. And we're working with our teammates across West Michigan to help improve stroke care. We're trying to keep people here in Michigan, our residents, people we train here. We want to keep them here. And so we're hiring our own residents and fellows within our system, and they're staying, which is great news. We're expanding and increasing our telemedicine capabilities, because not everyone needs to physically transfer away from the resources, like their family, to get high quality care. There's really good data that says patients that are with their resources tend to do better. We've also recognized that there are disparities in stroke care, and we're trying to work with different communities, underrepresented communities, to get them the care that they need. But sometimes the kind of communities you think of as the underrepresented are a little atypical. I'll show you what I mean. Here we're working with our neurology residents and fellows outside the four walls of the hospital to connect with the community in groups that don't traditionally seek the same kind of healthcare and have access due to language and cultural barriers. It's amazing how significant language can be as a determinant of your health. I've been sick in a foreign country before. It's really hard to communicate what's wrong and understand how the treatment you're getting when you don't speak the language. So it's our requirement to treat them in the language of their preference so they understand. We're also starting a stroke in the young clinic. And this is a disparity we don't often think about because stroke in the young often goes under-recognized. Because how could someone young have a stroke? It's a disease of old people. Well, it wasn't that long ago, for those that remember, women didn't get heart attacks, only men. And for a while, women were dying at significantly higher rates than men because we said, you know what, women don't have chest pain. It turns out women have a different symptomatology. And so we were ignoring women and they were dying at higher rates for cardiovascular disease. So let's not do that with our kids. Appreciate the time here. I'll leave you with this quote from Catherine McCauley, who helped start Trinity Health St. Mary's. Do all the good you can, by all the means you can, in all the ways you can, in all the places you can, at all the times you can, to all the people you can, as long as you ever can. Thank you.
Thank you, Dr. Francis. And since he mentioned women and heart attack, I will just mention today is Go Red for Women Day. So you'll see I've put some of our red dresses out. We have a few more pins, but for all of us to remember. Next, we have Dr. Chow from UM Health West.
Thank you very much, everybody. Thanks for having me here. I also want to thank my friend Brandon for basically giving a much better version of the talk that I'm just about to give. So I appreciate that. First of all, I actually do want to thank everyone for the invitation. When I first got the invitation to participate, I was pretty excited. I'm going to totally confess, then when I got the email attachment from Anita with the 130-page health report, I'm not going to lie, I started to have some second thoughts. But I will say that it was a really good exercise for me, and I think this whole thing is a really good exercise for all of us, because I sort of view this as a very data-driven opportunity for all of us to sort of rethink and maybe redirect our priorities in terms of how we want to deliver healthcare here in our neighborhood in West Michigan. So yeah, my name is Clifford Cho. I probably should have said this earlier, but I'm relatively new to the neighborhood. I started as Chief Medical Officer at University of Michigan Health West this past summer. Kind of like Dr. Francis, I also have a side hustle. In my case, I do surgery for people with liver and pancreatic cancer, and I also do cancer immunotherapy research, and so I also have faculty appointments down the street at the Van Andel Institute and across the way at the University of Michigan Medical School. What I wanted to do today was I wanted to kind of give you my, personal reflections on some of the things that I either learned or maybe was reminded about based on the content of the report. And specifically, I think what I'm going to talk about is sort of my, reflections on, how our population really is changing in terms of how old we are, our mental health. I'm going to talk a little bit about our lung health, and a little bit about how we're actually utilizing healthcare here in West Michigan. So I'm going to start with a story. As I mentioned, I relocated here. I was in Ann Arbor for a long time before coming here. And so bear with me for a second. So my daughter was in high school, public high school in Ann Arbor. And every now and again, she would have a swim meet or a water polo meet against a school from West Michigan. And whenever that would happen, three things would happen. One, like when the two teams would line up for like the national anthem and stuff, we would always be struck by how many like 6'4" 10th graders they have in like Hudsonville, you know, stuff like that. So that was the first thing that would always happen. The second thing that would always happen is we would lose. And then the third thing that would often happen is at some point when it became evident that we were going to lose, somebody in the stands or parents or so would sort of say something about how the West Side is the best side. I have to say now that I'm here, I totally see it. But one of the things I learned from the Health Check 2025 report was that I'm not the only one who's seeing it. I mean, a lot of people are clearly seeing it, and it's very evident. I think it verifies what we've all kind of noticed, which is that the center of gravity of our state's population is clearly moving from Detroit to Grand Rapids. These are some sort of additional supportive data that Dylan Fassett, who's in our strategy office at University of Michigan Health West, was nice enough to find for me. And I'll particularly use the bottom curve. The top curve is basically just saying that, you know, Michigan is actually, in some metrics, growing a little bit faster than, or at least is projected to grow a little bit faster than the rest of the country. But I also want to use the bottom chart to sort of emphasize the point where the dotted line is sort of where we're at now, roughly, and we're at a tipping point here because this population growth, as was alluded to by Dr. Kirby, is not even. It's really solely because of those of us who are above or of age 55 or older, and I say those of us because I just joined the group recently. Thanks for having me. But if you'll actually see, so the dotted line is the segment of the population that's 25 to 54, remarkably stable. The sort of solid, heavy dotted line are those of us who are eligible for AARP, and we're the ones who are actually increasing. And with the solid line are the legitimate youngsters, people who are younger than 25. And that line has been steadily dropping. And so this population growth, I would say, is almost entirely represented by those of us who are 55 and above. And as was alluded to, the types of medical care that our cohort needs is obviously a lot different, a lot more frequent, a lot more complex than the type of care that the other demographic cohorts are going to require. I think I point this out because, again, having come from the east side of the state, there are a lot of hospitals, there are a lot of big hospitals in the Detroit area. I worked at one of them. And I also want to sort of bring out the point that I don't know that our hospital infrastructure is necessarily keeping up to speed with the pace of that demographic shift. These are just some data that I found off of the internet, so take it for what it's worth. But you can find a lot of data on the internet, and this is just how many, what the local population is per acute care bed in the Detroit area versus the Coma area. And as you can see, I understand that our utilization is a little bit different than what's seen in Detroit. I also see that we're sort of narrowing that gap. But nevertheless, every hospital bed in the Detroit area is there for approximately 334 of the local population. Do the same math here, every hospital bed that we have is available for every 485 patients. And so I think this is going to eventually catch up to us. And I do think that we're going to have to make some sort of resource decisions about, how our health systems distribute care on this side of the state. I think I knew this. I think all of us knew this, but nevertheless, it's always striking every time someone shows you a new quantifiable measure of the prevalence of mental health illness in our country. And that was clearly evident in the Health Check report. These are data that are really specifically for Kent County that our strategy office was able to locate for me. But nevertheless, I think it reflects what's going on in the rest of the state, as was evidenced in the report. So in Kent County, 1 in 4 of us is suffering from depression. If that group of us is composed of just women or just LGBTQ or just people with disabilities, that prevalence increases closer to 1 in 3 or 1 in 2. Obviously, if you've got a problem that's affecting 1 in 2 or 1 in 3 or 1 in 4, it's really affecting all of us, obviously. And this was alluded to in the Health Check report, but just a little bit of quick math. And this is why I really want to applaud Brandon and Trinity's efforts to expand our inpatient mental health capacity, because I view this as a desperate need. But right now, the number of inpatient beds that we have available for mental health care is sufficient if roughly 1 in 1,000 of these folks ever require a hospital bed. And you might think that that's enough, but as Brandon alluded to, if you just walk around any of our emergency departments or any of our hospitals and bump into the many people who are sort of sitting around waiting waiting for an inpatient mental health bed, it's pretty clear that capacity is insufficient. And so I think this is clearly going to require some type of a foundational restructuring of how we're delivering care for this segment of the population. Another thing that struck me, and Dr. Kirby spoke to this quite eloquently, was just the amount of asthma, reactive airway disease that's going on in this part of the state. And Dr. Kirby had some very compelling arguments as to, it recognized people aren't smoking as much, but this e-cigarette thing is really noticeable. I do want to point out something else that I think could be a contributor to this, that I think we should all be mindful of. And that is the influence of other environmental causes. These are data that were actually shared with me by a University of Michigan group that's actually working on a program to not only do research, but education around just lung health across the state. But this I thought was fairly striking. But, in addition to cigarettes or e-cigarettes, let's not forget that there are a lot of other environmental factors. Lung health is a direct reflection of the quality of the air that goes into our lungs all the time. And so things like pollen, ragweed, the fact that all of our summers sequentially are getting noticeably hotter and noticeably longer, another contribution to airway disease. Seems like at the right time of year, there's some part of this continent that's on fire nowadays, and we cannot dismiss the influence that has on our lung health, nor the influence that poor housing conditions have. I always, I love going out to Lake Michigan. I always had this notion that the air was fresher on this side of the state because, like I just said, the west side is the best side. But look at this. So this is a report card, and it turns out that's not actually the case. 2 of the 3 counties in our state that qualify for a grade of F when it comes to particulate pollution and ozone levels are Muskegon and Ottawa. And so, I think this is a reality that I think we also have to be mindful of that could also explain, I think, some of the prevalence of reactive airway disease that we're finding. And this was alluded to previously, but as I see it, I think all of these trends, increasing in elderly care, elderly population, increases in mental health burden, increases in airway disease, they all converge on certain points. And I will tell you that one place where they all converge in a very chaotic way is in our emergency department. I thought it was rather striking that West Michigan used to be, but is no longer, a low outlier in emergency department utilization. I also noticed that the places where we seem to be getting a little bit closer and closer to Detroit in terms of overrepresented diseases in our emergency department are all the diseases we just talked about: asthma, depression, and then all the diseases that are associated with our elderly population: heart disease, back pain, diabetes, etc. And so this is my sort of synthesis, I guess, my takeaway from the report. And again, I'm very grateful for the opportunity to have been able to not only read the report, but also to have heard it explained to me. And that's this. A lot of us on this panel, we belong to regional, statewide, sometimes national healthcare systems. And I think all of the systems to which we belong, I think, should probably spend some time thoughtfully and intentionally considering shifting the focus of some of the ways in which we distribute healthcare in our health systems toward the west side of the state. I think all of the arrows and directionality in the report could clearly point to the fact that the utilization and prevalence of high complexity, high cost care is going to continue to increase in this region. And I will say that that sort of situational awareness of that reality, I would estimate is shared by approximately 100% of the healthcare providers that I know anyway. And then finally, on a more granular level, what I've learned is that I think we need to pay particular attention to elderly care, mental health, respiratory illnesses, and thinking of better and more efficient ways of using our ED resources. Thanks very much.
Thanks, Dr. Chow. Next we have Ms. Leslie, who's from Corewell Health. Thank you.
Thank you so much. Thank you for having me. I'm excited to be here today. And I'm a hospital operator, so I actually have a little bit different lens on this particular data that I'm going to share with you today. And so the question, that was asked was, when I review this, what sticks out at me? So I'm going to just give you my 2 cents. This is not necessarily data from the Health Check report, but this is data that is widely known, right? We know we have a significant aging problem, not just here in West Michigan, but throughout the country. And so for me as a hospital operator, I think, oh my gosh, where are we going to put all these people, right? We've talked a little bit about our bed situation and really, needing more hospital beds. But we also know that, I'm 49 and a half, in the next 15 years, actually, we'll then see a really sharp decline. So we need to make sure that we have enough capacity, but yet then what happens after 15 years? So it's really thinking about, how do we take care of these individuals, for the next 15 years or so, and then what? And so I'm going to talk a little bit more about kind of what we're doing to really help mitigate the need for hospitalization. I think the other thing that, really struck me as we think about the aging population too is just the payer mix that comes with the Medicare and the Medicare Advantage. Currently that is our lowest reimbursing group of people. So having more volume, in our historically fee-for-service world at a lower rate of pay doesn't make sense for us to be able to care for all of these individuals. So thinking about that is also something that, quite honestly keeps me up at night. The other piece of the report that really struck me was the workforce. And this is something, I'll be honest, we're feeling right now in our organization, and I'm sure my colleagues are as well. But there's a huge shortage of direct care professionals in healthcare that is happening. But not only are we experiencing in healthcare professionals, but we also need individuals, a workforce to be able to clean our facilities, or facilities team members to be able to maintain our facilities. And so it is just a workforce problem that we're experiencing. And so we have to think differently about how do we think differently about the way we deliver care and, as far as the future. So really, the other thing about labor that I think about too is, right now our workforce shortages are leading to significant burnout. And that's something that we're focused heavily on within our organization is how do we help protect our individual, coworkers and colleagues to not have to face burnout. If you look at the burnout rates for physicians and nurses, they're very high. And this is very troubling. Since the pandemic, we've seen many healthcare practitioners leave healthcare to pursue other opportunities. And so while again in the report we got to see some promising data as far as people going into healthcare, which is fantastic, it isn't enough because our healthcare workforce is also aging. And so it is something that worries us a little bit. You can also see there the Michigan turnover by profession. And, MAs is another group that we're seeing significant turnover and churn in those roles as well. The other thing is we have 4 generations in our workforce currently, and that is a challenge too. I'm someone who will work as hard as I can at all hours of the day or night, but the younger generations that are coming in really are looking for flexibility and career development and meaningful work. And that's very different. Not really in the sense that, I think we all in healthcare sign up for meaningful work, but it's the flexibility and the ability to have a really nice work-life balance that is important. And so we have to fundamentally change the way that we've done things over the past. Pre-pandemic is really, changed when we think about resident hours and, just again, our workforce and, the amount of times we're calling to say, hey, can you work today? Even though it's your day off. That is a very common practice even today. And it's something we're hearing from our younger generations that they're just not interested in. So again, it means that we have to change the way we work. And then, also when we think about, working top of license, we're hearing from a lot of our practitioners that they feel like we're underutilizing their skills and talents. And I'll talk a little bit more about that too. So, when I think about this math equation, we've got more patients, less reimbursement, and a workforce shortage. It doesn't add up. And so again, we really have to think about how are we doing it differently? What are we going to do differently to be able to care for our communities and to be able to provide the level of care that our individuals need? And so again, I'll talk a little bit about that. One of the things that I think we're all looking at is automation, right? What can we automate? And when we look outside of healthcare, for those of you who are in the, economic business school, you probably think, well, no kidding. But for us in healthcare, we're sometimes not so innovative when it comes to these things. But as far as automation, it is really thinking about how can we figure out how to do the work with machines. Things like floor scrubbers that are robots, right? Is what we have in some of our hospitals, or Pyxis, machines that are pulling medications for our 1,000 patients that we have up the hill in our hospitals. It's those kinds of things where we can become a little less reliant on people. When I say that, it doesn't mean, healthcare is so heavily people dependent that we have to think differently about, kind of the way we work. I talked a little bit about top of license, but I think that's something that we're very focused on as well. A perfect example of that is we have a project called our Helen Project, where we've partnered with a local entrepreneur to support our nursing colleagues. And so with the Helen Project, it's actually an app-based program that, with a concierge in our hospital systems that allows our nurses to be able to, focus on nursing tasks and then have a concierge who does non-clinical tasks, do the other work. A good example of that is a nurse is going to prepare and administer medications. They go to the bedside, they get all the medications out, they do all the double checks and all the things they need to do, and then there's an empty glass of water for the patient, right? And so essentially what happens is, they dial up a concierge through an app with touch of a button, they bring in a glass of water, and so the nurse never misses a beat, right? They can continue to work and they can continue to function and don't have to then lock up all those medications, go get a glass of water. It's simple things like that that really, I think, are going to make the difference. And then as we think about AI and technology, of course, AI is the buzzword, right? Everybody's talking about AI. But really, we have to think about how we utilize that in healthcare, but we also have to be careful, right? There's bias that happens in AI, and there are people's lives at stake. And so if we don't get it right, it could be incredibly detrimental. And so how do we leverage AI technology in our spaces in a way that is safe? One example that, not just, I think every healthcare system is doing in terms of radiology, our radiologists, basically read from a work queue. And so many have, behind the scenes, an AI tool that is reading the studies and then putting studies that are highest risk, or that the AI tool flags as, there might be something here. Put that at the top of the work queue for our radiologists. So it's just one example. Again, they're not reading, they're just kind of saying something looks off here. Maybe you want to take a look at this one first. And so it's things like that we're starting to really utilize as we think about our workforce in that regard. I want to talk a little bit about, as we talked about the data around, seeing a reduction in our emergency department visits, and as well as hospitalization. So one of the things that we've employed is advanced primary care, and so this is really where we take the patients who are at highest risk, the most frail individuals that we have. within our primary care space and put them, all in one clinic where then the wraparound services, and my apologies, that's very tiny, but that, the wraparound services are there in that clinic. And it's very different than what we think about when we think about our normal primary care experience, which is, I don't feel well, I'm going to call the physician or I'm going to call the office and get an appointment. This is really where the office is calling to say, hey, Mr. Smith, we haven't seen you, we need to see you, or how's your hemoglobin A1C today? So again, it's really a model where, it's the wraparound services, social worker, pharmacist, everybody working together to care for that individual. And so you can, kind of see here in our advanced primary care clinics, we've actually seen a 6.5% reduction in hospital admissions, as well as ED visits reduced by 1.1%, which, I guess in a way it doesn't sound all that impressive. However, when you think about these are our highest utilizers historically, I think that really does speak to, really the work that is being done, not on the screen, but also we've seen a real reduction in hemoglobin A1C in these clinics, and 95% of the patients in these clinics are below 9, which 9 is not a goal, but, in a space where we saw lots of hemoglobin A1Cs of 12, 13, 14, that's really something remarkable. And then just the last thing I'll share, again, as we think about how are we doing it differently, virtual ICU is something that we have within all of our West hospitals. And this is something that, quite frankly, saved us during the pandemic, where we've got expert clinicians who are able to look across and look at data that is coming in from patients in ICUs across our organization and be able to kind of have a second set of eyes with expert nurses and expert physicians, to be able to kind of help support the team. They're able to talk to patients in the room. They're able to talk to clinicians in the room. And so again, they're really helping to really provide better care. As a result, Corewell Health West is in the top decile in the nation for mortality. So something really impressive to celebrate, and I would attribute a lot of that to this as well. So again, just wanted to highlight some of the things that we're working on, but the work doesn't stop. And I think, through this data, it really, highlights the need for more innovation and more thinking about how we do it different. Thank you.
Thank you. Now we have Director Hertoff from the Michigan Department of Health and Human Services.
Oh, good morning, everybody. I got up at 4:30 to be here. Good morning, everybody. I'm really tired. Just want you to know that up front. Okay, and I have a lot to go through in 10 minutes, but I'm really excited to be back with you this year. I really enjoy this discussion and all of the information that's shared here today. So I just want to talk today about the overall work that we do in the department. So it's going to be a very different perspective than you've heard previously. And then the priorities that we have in the department related to health outcomes, and then the investments that we're making at the state level that I think are relevant to what we've identified in the health check this year. So our mission is to promote the health, the safety, and the prosperity for the residents of Michigan. And I'm really, really proud of the work that we've accomplished in the last year. So just a few items here, but that does include working to strengthen that healthcare workforce, improving access to behavioral health care, and keeping kids safe. We know that there's always a lot more work to do, but I think we should always take a minute to celebrate how far we've come. As director, one of my top priorities, and a central topic that I know has been mentioned today, is increasing access to behavioral health care. I believe that everyone should have access to behavioral health care when and where they need it and the level that they need it at. We continue to build out new options to create a broad array of services and resources for both children and adults where we know that gaps exist. Additionally, we have invested and collaborated with partners to strengthen the behavioral health workforce. Some of the investments that we've made here include offering grants for additional child and adolescent health centers and school wellness programs so that we have access to mental health services in schools, which we've heard from many students is something that they not just want, but are demanding. establishing these crisis stabilization units as well as psychiatric residential treatment facilities to take pressure off of those emergency departments and inpatient facilities. We do have such a great example here in West Michigan between Trinity Health and Network 180, and I was just asking Bill the other day how I can get everyone else across the state to do this. It's been so successful. Expanding the number of our certified community behavioral health clinics to provide comprehensive, high-quality services to people in Michigan, regardless of their ability to pay. And implementing the Michigan Child and Adolescent Needs and Strengths tool, which we call MichiCANS, which is standardizing the assessment for children in the child welfare system and the behavioral health system. Previously, there were multiple assessments occurring multiple times. And then we were recently selected by CMS to participate in the Innovation in Behavioral Health model from CMS to provide an enhanced level of care to dual enrolled Medicaid and Medicare beneficiaries. That's a lot. That's a lot of things. I am really, really proud to say that Governor Whitmer, this administration, has invested more in behavioral health services expansion than any other administration ever, over $100 million. We were very fortunate that we did receive significant funding from the federal government as a result of the pandemic, which allows us to invest in building a new state psychiatric hospital, expanding the capacity that we have at the state level, and then really focusing on those transitional locations outside of the expansion of the inpatient beds. We want pre and post opportunities for people because we don't think everybody needs to go into an inpatient bed. You shouldn't have to go into an inpatient bed unless you are truly having a psychiatric issue. People who are chronically depressed and maybe have an acute episode probably don't need to be in an inpatient bed, but 72 hours in a crisis stabilization unit could be exactly what they need. We also are very concerned because when people are ready to be discharged from those inpatient settings, they don't have anywhere to go. So our focus has really been on expanding that, and we've been incredibly successful in doing so. Obviously, strengthening the healthcare workforce is an important part of access to care and has been a barrier over the last increasingly 10 years, but especially since the pandemic. Burnout, wages, and turnover, as were mentioned, have significantly reduced our workforce in the state and across the country. So we continue to work collaboratively to find solutions externally, but also inside the state. The Michigan Department of Health and Human Services has 5 psychiatric hospitals. We also can't hire nurses, and we pay less than you do. Department of Corrections also has clinical staff. They also are having a difficult time. So we feel acutely the same pains that you have. Some of the investments that we are making here include increasing wages for direct and non-direct care workers, especially in the nursing home settings and long-term care. Expanding our student loan repayment programs for nurses and scholarships or stipends for students who are studying behavioral health. We've been able to invest state general fund, specifically toward the behavioral health workforce. The first year that we opened that student loan repayment program up, we had 100 slots and 1,000 applications. So there is a need. We've tried to align Medicaid reimbursement for non-physician and physician rates in behavioral health and grants for continuing education and exam fees to people who are working to increase their degree level and their skill level. Working to address the opioid crisis and substance use disorders. With key investments on this, we continue to work to help people find their journey to and throughout recovery in the state. This current year, so fiscal year 25, has $300 million in it for evidence-based practices in prevention, harm reduction, treatment, and recovery support, which include expanding hospital supports for substance-exposed babies and their families, and removing prior authorization requirements for medications to treat opioid support, which after having done that, we've seen a 20% increase in prescribing out of those primary care offices. So that's been very successful. And then a focus on improving health equity. From my perspective, addressing inequities is a critical part of improving our health outcomes across the state, and we invest in programs specifically aimed at reducing those inequities from moms and babies through to older adults. the governor established when she came in 2019, which feels like forever ago, the Healthy Moms, Healthy Babies initiatives, and we have invested in doula coverage for moms and families covered by Medicaid. So they're actually Medicaid providers, one of the first in the country to do that, and helping to train more doulas across the state. Expanding our postpartum Medicaid coverage up to a full year after birth, increasing our home visits and supporting our perinatal quality collaboratives across the state. We also are ensuring that families have the resources that they need to decide when and if they want to have a family, and have access to other important healthcare services like cancer screenings. We recently started the Take Control of Your Birth Control program, where we offer free contraception through our community partners, both resources and supplies for free. We also really had an opportunity when it came to COVID to do a lot to address disparities. And so we established these neighborhood testing sites all over. And what we've been able to do is get funding, and we've transformed these neighborhood testing sites into wellness centers. It's amazing, where patients can just walk down the street to receive annual screenings and meet with on-site community health workers and clinicians in many places. We also bring mobile units to those facilities so people can be screened where they are. We've also expanded access for critical care for sickle cell disease and targeting public education on uterine fibroids, both of which we know disproportionately impact Black communities. And then we have taken a pretty comprehensive look at social determinants and other drivers of health, as I know many of you have done that as well. But we know that health outcomes are really, you've heard this, the 80-20 rule, 80% of your healthcare of your health outcomes are not determined by the time that you spend with a doctor in a hospital. So looking at factors like housing, access to food, safe neighborhoods, and this is why we continue to support innovative programs and initiatives in the state of Michigan. We have partnered with the Michigan State Police, for example, with our Safety Net Partnership Program, so that Michigan State Police, when they run across families who may need assistance, that if it is not addressed could result in some sort of penalty, legal penalty, work to help make sure that they have the resources they need to do these sorts of things. Your child's not in a car seat. I can't afford a car seat. Let me give you a car seat instead of getting a ticket. So we've been really successful in working on that. One of the things I talk about all the time is our Keeping Kids Safe agenda, really focusing on making sure that we're investing in our children, especially our most vulnerable children in the foster care system, and working through a number of social determinant programs with those children and their families aimed at reunification. And finally, I think that was the last thing. I know that we're doing so much work. We have thousands of employees at the state. We work so closely with all of our partners, not just here, but across the state of Michigan. And I'm really, really grateful for the continued work, the continued partnership in making sure that we are making progress and becoming one of the healthiest states in the country. So thank you again so much for your time.
So I'm going to have Director Hertel come back because the first question is for her. We have a few minutes for questions. Very easy to answer, I'm sure. Do you anticipate any challenges with the potential actions at the federal level to impact funding and data collection or anything else?
I specifically asked them not to include that in the presentation. Yeah, it's going to be rough. I mean, everything that we're saying to you today is based on a health economic forecast as of December 31st, 2024. I don't know what's going to happen. We are preparing for any number of possibilities, but here's what I am fairly certain. Things are going to get very, very difficult before they get easier. And we are going to have to think about how to be creative when it comes to maintaining the access levels that we have in this state. But yeah, I fully anticipate that we're going to, it's going to be like a wild time. So, yeah.
We have a couple of really quick questions. One is a question of long-term versus short-term. Does long-term have a stop date?
Right now.
Right now. That's the answer to that. Okay. Dr. Francis, does Southridge support all ages? It appears that behavioral health is impacting the younger generations more.
Great question. Thank you. Southridge is an adult facility. We know our partners at Mary Freebred and Corwell have been partnering to create a child and adolescent facility. So there is another facility coming for children and adolescents. We recognize that is a significant problem. But like I said, none of us can do this alone. So we're grateful our partners are working on that area.
Thank you. Do we have any other questions? We have about 2 more minutes left. We do have a question here. Data from Corwell reference that greater than 20% of APPs feel underutilized. What are healthcare organizations doing specifically to advocate for full practice authority in Michigan, which is one of the most restrictive states for nurse practitioners?
Absolutely, we're advocating at the state level for type of license for all practitioners, but I can't speak to the specifics. I don't know.
Thanks. I know there's a lot of action going on at the state level trying to increase scope of practice legislation. So hopefully all of our healthcare providers can get behind that and really extend the care that we can give to our communities. Any other questions? So hearing none, I know there's a lot of information to digest here. This was a very meaty report, and I really want to thank all of our panelists. Let's give them a round of applause for their great additions that they made in helping us really digest these data and really look at the impact in West Michigan and throughout the state. So again, thank you to all of our amazing economists and our awesome panelists, to everyone who has joined us today, either in person or virtually. We all have a lot to think about, a lot of work to do. Thank you again to our sponsors, Blue Cross Blue Shield of Michigan, Blue Care Network, and Priority Health, for all of our GVSU and community contributors who really made this year's Health Check a reality and who are going to go forth and do important work, as we always do, based on all these data. So have a great day, and thank you so much for coming.